Hello, welcome, and thank you for joining today's webinar, Efficient Cardiac Imaging, Dream or Reality? I'm really excited to be here and talk to you about today's topic. Our speaker will be Dr. Melanie Atkins, who will share just how far we've come with technology in the area of MR for cardiac imaging. Before we start, just want to say a few housekeeping notes. First, this webinar is being recorded and will be available on demand in the RSNA course catalog. There will be time at the end for Dr. Atkins to answer your questions. So we do invite you to answer questions in the chat feature. And we really want this to be an engaging discussion. So please think of questions and we'll answer them at the end. This slide contains important information about receiving your certificate of attendance for this webinar. And I'll give you a minute to take a look at this. And let's move on to the main content for today's topic. Efficient Cardiac Imaging, presented by our esteemed speaker, Dr. Melanie Atkins. Dr. Atkins is the Division Chief of Cardiovascular Imaging and Medical Director of Advanced Cardiac Imaging in the Inova Health System and at Fairfax MRI Center. I'll turn it over to you, Dr. Atkins.
Thank you, Anya, for the introduction. So over the next 45 minutes, I hope to take you on a journey to convince you that we can truly efficiently scan patients of all kinds. This webinar is not going to focus on the healthy 25-year-old in normal sinus rhythm, or we're not scanning Michael Phelps who can hold his breath for 2 minutes. So this is really the entire population from our neonatal cardiac MRs and our pediatric congenital heart disease, all the way up to our elderly patient population and those with cardiomyopathies and devices. So we're going to start with where we are today with deep learning image reconstruction in both CINI and non-CINI acquisitions. We're going to move to our second part of the talk, discussing free breathing cardiac MR protocols and what we're doing today, but also what we plan to do with leveraging new technology. Then we'll move to scanning patients with devices, both cardiac and non-cardiac metallic devices. And finally, we'll finish with quantitative myocardial perfusion. And I hope that I can convince you that leveraging some of this new technology will really make excellent quantitative myocardial perfusion. And finally, AI-driven cardiac MR scanning. So we all know that cardiac MR is challenging. It's challenging for everyone involved, including the technologist, the cardiac imager, and the patient. So we really need to come to a goal of being able to scan all of our patients in a 15-minute time frame. So what are some of the problems that we have today? So cardiac MR is traditionally, because of the long acquisition time, acquired as a segmented technique. So our conventional approaches, they take little pieces during each heartbeat, and then they stitch them together to make our nice cine image that we're used to having. So in a patient who's healthy, who can hold their breath, who has normal sinus rhythm, we can acquire these beautiful images in a segmented technique. However, when you think about it, this is just one image that we had for a 10-second breath hold. Then we have to scan the entire cardiac left ventricle and the entire heart. And so now we have to repeat that 12 to 14 more times to get our entire cardiac cycle. And then we have to do it in different imaging planes. We need parametric mapping, we need delayed enhancement. All of those are acquired in the same way traditionally. And that is like a pulmonary rehab workout. So what is our goal here? We really need to do high quality, high SNR, rapid free breathing acquisitions, and we want to get the patient in and out. We know that with longer exam times, our patients are less able to comply with our exams. So AirRecon DL has been around now for a number of years and instituted into all of our non-CINI applications that we can see here. So our black blood images we can acquire in a single shot technique. Our first pass perfusion images and semi-quantitative perfusion images, all of our delayed enhancement imaging. We can also acquire our single shot PSMDE in a free breathing technique, which we'll talk about in more depth later, our parametric mapping, and even our pre-ablation patients where we need 3D delayed enhancement imaging. So when we think about our conventional reconstruction, there's a very narrow window where we have acceptable scan time and acceptable SNR. So it's always that constant match with conventional reconstruction, and it's really a very narrow window. However, with the application of AIR Recon DL, we can really expand that clinically acceptable SNR and scan time window. And so we can have much faster acquisition time while still keeping really high clinically acceptable SNR. However, cine imaging is really our mainstay of cardiac imaging. So we also need a faster, high quality cine imaging. And that's where Sonic DL came into play. So that is the integration of deep learning image reconstruction also with parallel imaging. And the beauty of this is you can choose your degree of acceleration and the utilization along the R to R interval depending on the use case that you need. So with the current product Sonic DL, to maintain temporal resolution below 45 milliseconds and a 1.8 millimeter voxel size, we recommend utilization of 3 heartbeats. So the importance of this to remember with the heartbeats, so we think about our first example, we acquired that image over 10 heartbeats. The Sonic DL in the middle, you can see here, was acquired over 3 R to R intervals versus our single Sonic DL single heartbeat is acquired just over 1. And that's really excellent for our patient population who has arrhythmias, shortness of breath, where we really need the imaging to be closer to physiology. And so that is acquisition speed also matched to our physiology. And so we can then, these patients with really severe arrhythmias, we can still get excellent image quality. So Sonic DL, how does it work? It is a physics-based deep learning reconstruction that's highly undersampled with an unrolled model in a deep learning architecture. And this data consistency is applied to enforce consistency across that acquired data. And it then reconstructs these very high SNR, high fidelity images that have been shown to outmatch compressed sensing. When we started working with Sonic DL, or the research sequence that was called DL Cine a few years ago, the first abstract was looking at, does the DL Cine and our standard SSFPs have accurate function calculation? So this was our first abstract that we presented with 63 patients looking at mean and standard deviation between SSFP and DL Cine, and we found that there was really a negligible difference in function. And we also found that the image quality was superior with DL Cine compared to standard conventional SSFP. And then the best part about this is a real improvement in acquisition time between the standard SSFP and the DL Cine. But we really needed to look at, well, here's an example from that abstract showing on the left-hand side our standard SSFP images, on the right DL Cine images, and I think you can appreciate there is some blurring here in patients where we have some heart rate variability versus excellent image quality on the right. Next, we set out to answer the question, can we integrate Sonic DL into our clinical practice? And we presented this abstract at RSNA last year. We looked at 70 patients over a multitude of age ranges, and we scanned a standard SSFP, a Sonic 3 R to R, and a Sonic 1 R to R, and we compared scan times, image quality, and a volumetric analysis. And this abstract was featured in the Daily Bulletin last year during RSNA. And what we found is that, as you can see here, there's a significant difference in scan time between the 3 acquisition types. The standard SSFP was significantly longer, and when we utilized the Sonic 1 R to R, we had an 80% scan time savings compared to standard SSFP. Now, a reminder here that the time of acquisition, this is not tapping time, this is our entire acquisition time. So that does include the breath holds in between each slice acquisition. Here are the Bland-Altman plots of comparison of the volumetric techniques. You can see that there's very little difference between the techniques, and similar to what we expect with inter-reader variability. When we look, this is a patient with HCM that we scanned in all 3 techniques. You can see in this example, we have excellent image quality in the conventional SSFP and both the Sonic 3 R to R and the Sonic 1 R to R. So let's do a couple case examples. This is a 76-year-old patient with shortness of breath, an abnormal echo, and he was sent for an evaluation of cardiomyopathy. It is important to note that he had a very high PVC burden on his Holter monitor and was part of the reason that he was sent to us. When you look at, these are the tapping times for the acquisition, the standard SSFP, you can see the images are severely marred by the patient's PVC burden. And we would not be able to do accurate function calculation with this image quality. You can also see that on the 3R to R, we are still suffering from the patient's arrhythmia, because remember, 3R to R is still a segmented technique acquired over those 3 heartbeats. So in this patient with a severe arrhythmia, the 1R to R is really the best option here. We can now obtain good function data, and we can look for wall motion abnormalities. Our next patient is a similar patient, 76-year-old male, also with an arrhythmia. This patient is a claustrophobic patient with shortness of breath and was sent for an abnormal echocardiogram demonstrating demonstrating aortic stenosis and left ventricular hypertrophy. When we look at our short axis images, again, you can see that the patient's arrhythmia causes a significant amount of artifact on the conventional SSFP images, and we have much better image quality on the sonic DL 3R to R and 1R to R. And we can see we have circumferential left ventricular hypertrophy here, which is asymmetric in the septum and anteroseptal inverse septal walls. But I think what this case really highlights, when we look at our 3-chamber view, where we're getting a nice look at our aortic valve and our mitral valve here on conventional image reconstruction, I think you can appreciate that it's very difficult to see the aortic stenosis, the aortic insufficiency, is not well visualized. And also this posteriorly directed regurgitant jet that we can nicely see on the sonic DL images is really difficult to appreciate. Whereas when we look on our 3R to R images, you can see the aortic stenosis, the aortic regurgitation, the posteriorly directed regurgitant jet, and you can also see the dephasing in the outflow tract from the left ventricular outflow tract obstruction. Our next patient example is an 88-year-old male with a new onset cardiomyopathy. This patient again was having very much difficulty breath holding during the exam. And so you can appreciate that we have both respiratory and cardiac motion in the standard SSFP images. When we did sonic DL, the 3R to R and 1R to R, we can appreciate the wall motion far superior and less blurring from than we see on the standard SSFP images. And this is, of course, an example of cardiac amyloid. These are single shot phase sensitive MDE images utilizing Air Recon DL, and we can acquire these in a free breathing technique and very rapidly in 1 to 2 breath holds or respiratory triggered. We can appreciate the diffuse subendocardial delayed enhancement in this patient with amyloid. And at our facility, we've started running an additional stack of single shot PSMDE images in these patients where we select amyloid, adding 100 milliseconds to the TI time, and that really gives you better visualization of that subendocardial delayed enhancement and the adjacent myocardium. Congenital heart disease is really an excellent story for sonic DL. Our congenital heart disease population, they are routinely coming back to us for frequent follow-up examinations, and they have very challenging anatomy. So we need to be able to image them in many imaging planes and very rapidly. And this is an example of a 17-year-old hypoplastic left heart syndrome patient, status post bidirectional Glenn and fenestrated Fontan. And when we compare our sonic DL images versus our conventional SSFP images, I think you can appreciate that we have excellent image quality on both. However, if we can save that time and acquire the sonic DL images, then we can spend it and utilize it for other things. We can appreciate here this patient has a fenestrated Fontan. We're looking at our AV valve, which is a tricuspid valve. In this case, we can appreciate nice tricuspid regurgitation. And so if we don't have to spend the time on the conventional SSFP images, we can really utilize that imaging time to scan in other imaging planes. And here's a 4-chamber view. Again, we can see the patient's fenestration, the extracardiac Fontan, the very hypoplastic left ventricle, and our systemic right ventricle with moderator band. And the 40 flow image was just placed here to show you and prove to you that we have this posteriorly directed regurgitant jet and our small fenestration. So should we change to 1R to R for everybody? We know the volumetric analysis is similar. We know the image quality is adequate for our functional measurements. But the SCMR criteria recommends a temporal resolution of 45 milliseconds with a voxel size of 1.8 millimeters for all standard SSFP imaging. So can we achieve this with Sonic DL? Well, we can with the Signa Sprint. So the new Signa Sprint is a high gradient 1.5 Tesla scanner. So if you can see, we've got 65 200 gradients, which is what we're used to on our high-end 3T. So we've taken that high gradient power and put it into a 1.5 Tesla scanner, which is a dream for cardiac imaging. So we've got the gradient power that we have in a 3T, but not all of the problems that we run into on the 3T with cardiac imaging with our susceptibility artifacts and many of the struggles that we deal with 3T imaging for cardiac. So these are some examples. I had the opportunity to scan on this magnet back in May, and these are some of our volunteer patient examples that we acquired that day. This cine on the left is actually from our facility, utilizing our traditional gradients at our magnet we have today. And so you can appreciate, we acquired this image on the left at a 38 field of view. And in order to keep the temporal resolution as close to 45 milliseconds as possible, we had to increase our voxel size to 2.1 millimeters. You can see it's still a very rapid acquisition, but utilizing those new gradient power that we have on the high gradient 1.5 here, we can come down to a field of view of 25 centimeters and then achieve our 1.8 millimeter voxel size. I think you can appreciate here we've gone significantly less, significantly decreased on our TR, our min TE as well, and still important to note that with 1R to R, we can acquire these free breathing with respiratory triggering. So excellent for our patient population who's unable to hold their breath. Another couple examples here, we have traditional gradients. Again, notice our classic 36 field of view. When we try to really push that resolution to smaller field of resolution or to a 1.6 millimeter voxel size, again, we struggle to really meet that more rapid temporal resolution versus here, field of view of 22, we've gone down to a 1.3 millimeter voxel size and still a rapid acquisition. And hopefully you can appreciate really beautiful image quality with those 18 and 16 centimeter field of views. And that's really the beauty of that high gradient power. So what are we going to use this for? Small field of view pediatric imaging. We need also that temporal resolution in small mobile masses. If you think about trying to catch the fibroelastoma on the aortic valve, a lot of our problem here is that we really need that temporal resolution, and they're oftentimes small. Valvular insufficiencies, keeping that rapid temporal resolution in our valvular insufficiencies as well. This is another example of the two. You can see here we've gone, if you can appreciate, quite a difference in our TR as we've gone down to this 1 millimeter temporal or 1 millimeter voxel size, 22 millisecond temporal resolution. So this small field of view imaging that we can leverage this gradient power really is going to help us with our pediatric population and those areas where we need very small field of view imaging. More of the same here. You can see that we've on a 22 centimeter field of view, we've gotten to a temporal resolution of 12 milliseconds at a 0.9 millimeter voxel size. Kept the matrix quite high here, so you can see just excellent image quality for these cine images. And then our 4-chamber and 2-chamber cine images here as well, also showing that we can still acquire a 1 millimeter voxel size with a 12 millisecond temporal resolution. So really beautiful image quality. So how are we going to leverage this high gradient system? We can now do a fast, completely free breathing cardiac exam. We can change our standard 3R to R to 1R to R. So this will be truly achievable across the board. All of our SSFPs can therefore be performed with free breathing and respiratory triggering. Like I've shown in the previous slides, we can achieve those lower TRs, shorter TEs, and faster temporal resolution, excellent image quality. And it's really going to be great for our pediatric population, patients with arrhythmias or can't hold their breath, metallic devices. quantitative perfusion, which we'll talk about later in the talk. So we're going to switch gears a little bit here and talk more about free breathing. In our practice, and across, of course, everyone, referrals for cardiac MRI, we have patients who are short of breath, they're in heart failure, they have pleural effusions, they have pulmonary edema, they often have atrial fibrillation. Claustrophobia in the MR scanner is a real thing. I know that sometimes we kind of forget about claustrophobia, but it's a significant amount of the US population has claustrophobia. So does free breathing really mean longer scan times? Well, not exactly, actually. If you start to think about how many times you have to repeat an acquisition, or when you have these patients who have shortness of breath or are symptomatic, you have to elongate the breaks in between the breath holds. And so that time really adds up. If you think about each acquisition has multiple breath holds, we end up spending a significant amount of time. And so if we could allow the entire exam to be free breathing, they'll have less fatigue, less scan failures. It's a more comfortable experience for the patient, especially patients who are coming back for repeat exams, our transplant population, our congenital heart disease population, our cardio-oncology population. So we want to be able to give them a much more comfortable experience. And then finally, when patients get fatigued and start overheating, that can lead to sweating, which decreases our lead efficacy as well and compromises our gating capabilities. So our protocol at FRC is shown here. As you can see, we're still acquiring black blood imaging in a stack. We are acquiring parametric mapping on every patient. We do a single 3-chamber and LVOT to have at least a better look at our mitral and aortic valves. We run a 4-chamber stack and then at 3 planes of post-contrast single shot PSMDE with the addition of air recon DL. And occasional, or in our current protocol, we're actually doing a 4th stack, which is a gray blood view to help us visualize those small subendocardial infarcts. This is a recent paper that was published comparing single shot PSMDE with air recon DL versus conventional segmented PSIRs. And in this paper, they demonstrated that it's 5 times shorter scan times, less motion artifact, and better or similar image quality. And this is an excellent example from that paper. On the bottom, we have our breath held segmented PSIRs. And you can see that you wouldn't necessarily be able to tell, is this real delayed enhancement here in the inferior infralateral wall, or is this motion artifact? So we can see our free breathing respiratory triggered single shot PSMDE. We can nicely appreciate the area of delayed enhancement. This is another example from our practice comparing segmented PSIR to our single shot MDE with air recon DL. When we changed our protocol over to acquiring single shot for everyone, we did a number of these just to compare image quality. We can see here in this patient with apical hypertrophic cardiomyopathy, the interstitial delayed enhancement within the apex. This is another example of a 76-year-old male with chest pain and shortness of breath. All of the images on the bottom were acquired with single shot PSMDE utilizing air recon DL, as well as the black blood imaging on the top was also acquired in a single shot technique. And this was a completely free breathing exam. And we can nicely appreciate this patient's diffuse pericardial enhancement, some pericardial edema in this patient with pericarditis. So this is an example of a 78-year-old male who came to us for evaluation of an RCA infarct and shortness of breath. This patient to evaluate for viability. All of these images were acquired free breathing. You can see our single shot PSMDEs with air recon DL here, as well as our T1 map. We like to acquire this gray blood image at our practice just to appreciate these very subtle subendocardial infarcts. And so I think you can really appreciate the entire infarct much better on the gray blood image while we still have dense contrast in the blood pool. And then we can appreciate that as well here on our T1 map. So we can also do, this is parametric mapping, again, free breathing. This patient, you can see is free breathing, and we've applied motion correction, and we get this very nice, beautiful T2 map. So we can now allow these patients to have free breathing during the acquisition if needed. T2 mapping is another important area to look for edema in the myocardium, and it's been a challenge for us to have a full pre-breathing technique. We were conventionally using multi-echo FSE-based T2 mapping, and we found that these are extremely motion sensitive. So we've started to use a research SSFP-based T2 prep sequence. And we demonstrated this abstract at SCMR last year. We looked at 46 patients. 11 of the patients had to be excluded from the evaluation because the multi-echo FSE-based was non-diagnostic. And we compared both a breath held technique and a respiratory triggered technique and looked at T2 values, image quality, and acquisition time. I think that everybody can appreciate this is the multi-echo based on the top, completely non-diagnostic evaluation. I don't think you could measure anything on this. Versus the bottom, you can appreciate actually this patient has an ICD, which we can't even tell on the multi-echo based. And this patient was able to be respiratory triggered and have a really beautiful T2 map. When we looked at acquisition time, we compared the standard or the acquisition time with the breath held SSFP-based technique versus the multi-echo as well as respiratory triggered. And we found that the respiratory triggered SSFP-based technique was statistically significantly shorter than the multi-echo FSE-based. And we think that's just because you have to take breaks in between each acquisition. And this is a patient comparing the two techniques and good image quality. When we talk about first pass perfusion, often patients cannot hold their breath during the entire perfusion exam. And so we can now allow these patients to free breathe during that entire acquisition. So we've got this large hypointense mass in the right ventricular outflow tract. On our first pass perfusion where we've applied motion correction, you can see that there's no increased uptake relative to the myocardium. And these are the single shots black blood images and PSMDE images, immediate and delayed. We can see we have low signal on both T1 and T2 relative to the myocardium. We have heterogeneous enhancement on the immediate, and we have this homogeneous delayed enhancement on the delayed exam, which are all classic findings of a cardiac fibroma. And so this patient who we have been scanning for many years, we now are able to offer him a free breathing exam. So we're going to change gears again and move on to talking about scanning devices. So we all know in our practice, I think we've all been able to appreciate the significant increase in devices over the last number of years. A study in Nature magazine showed an increase of 27 to 32% of patients aged 40 and over just in that 4-year time frame. That increase of patients with a metallic implant. Over 3 million Americans have a pacemaker or a defibrillator. The reasons for getting pacemakers today are increasing. And these patients frequently need cardiac MR imaging. And although the majority of them are MR conditional today, we still need special spanning protocols to have our adequate image quality that we're used to in patients without a metallic device. And I think it's also important to mention here that even off-label systems and abandoned leads can be scanned safely with appropriate protocols. So I always think that it's important to go back to physics and think a little bit about what's causing the issue with the metallic implant, because then you'll be better to be able to fix it. So of course, field inhomogeneities around that metal artifact, you're going to get off resonance artifacts, which cause the center frequency shift. So we want to keep short RF pulses, we want to keep decreased flipped angles, and we want to use wideband techniques. So if you think about our traditional segmented PSIR has a very narrow spectral bandwidth, and that's very vulnerable to artifacts because you're going to have an insufficient prep pulse time. So single shot PSMBE is wideband enabled, but you can also, in patients with really large metallic devices, you can also run them FSPGR based to decrease that metal artifact. And I always remind our technologists to raise the arm if the generator is causing an issue. So this is our FRC device protocol. We run, it's very similar to our free breathing protocol, as you can appreciate. The differences are here that we will switch to an FSPGR technique if there is significant metal artifact. So this is a very large patient, a patient with a BMI of 50 who has an ICD. They first presented to one of our facilities and they also have a history of sarcoid and an arrhythmia, I think that you can appreciate here. So we attempted to scan utilizing compressed sensing. And because of the patient's arrhythmia, we really struggled to evaluate any diagnostic image quality. So we brought the patient back and scanned them with sonic DL1 R to R to attack the arrhythmia issue. We can also see the patient's ICD here. We do still have metal artifact from the CAN, but it's not in the field of view. And it allowed us to really have a diagnostic examination. When we look at the comparison of this patient with the two types of delayed enhancement imaging. On the right, we have our classic segmented technique. Remember, this is not a wideband technique versus our single shot PSMDE utilizing wideband. And I think you can appreciate here, we can see the ICD lead, we can really nicely see the myocardium, and there's no evidence of active sarcoid, whereas it was much more of a non-diagnostic exam utilizing a segmented technique. This is another example of a transplant patient who had a leadless pacemaker placed in the early postoperative period secondary to heart block. These leadless pacemakers, we're starting to see them quite frequently in our practice, and they do cause a significant amount of artifact because the footprint of them is much more robust, not on a lead. And so you can see here when we utilized our standard single shot SSFP based MDE sequence, we still have a lot of metal artifact that is impairing our ability to evaluate the left ventricular myocardium. And so here we switched to a SPGR single shot PSMDE technique, and we can really evaluate the majority of the left ventricular myocardium. So this is the 4-chamber view of that same patient. Again, the SSFP based, large portion of the left ventricular myocardium is non-diagnostic here, whereas when we use an SPGR technique, we can really evaluate much more of the left ventricular myocardium. Our next patient is a patient not only with a pacemaker, but also a Lynx device. And I'm sure as many of you, we have struggled with really good quality imaging in these patients with Lynx device because they do cause a lot of artifact. And right at the gastroesophageal junction happens to be very close to where we're doing our cardiac imaging. And so you can see here in this patient, we were able to acquire sonic DL images and get good visualization of the myocardial function. And again, here it's very important to use an SPGR-based single-shot PSMDE to get better visualization of the left ventricular myocardium. You can see the SSFP-based still has significant metal artifact. Our next patient is one of our recurrent sarcoid patients. He also has an ICD, a 67-year-old male. All of these images were acquired sonic DL on the top left and middle. And here are our single shot PSMDE images with Air Recon DL. We can appreciate that this patient has patchy areas of delayed enhancement. And our black blood imaging, again, nice image quality where that ICD lead is really not affecting our visualization of the left ventricular myocardium. We can see that artifact in our T1 map, but certainly it does not affect our diagnostic capabilities in these areas of active sarcoid. So our next topic is quantitative myocardial perfusion. So in our practice today, stress perfusion remains largely qualitative. There are semi-quantitative post-processing uh, programs, of course, as we all know, but they do present many challenges and inaccuracies. And if you're like me in my practice, I think we all struggle with the semi-quantitative post-processing. So we really need quantitative myocardial perfusion. We need to remove that subjective component. We need to be able to accurately quantify myocardial blood flow and myocardial perfusion reserve. And then it's also important for the evaluation of microvascular dysfunction, which we cannot evaluate in a qualitative technique, and then our transplant population and our cardiac allograft evaluation. So the beauty of the Cygnus Sprint is we'll be able to leverage that gradient power and remove the challenges of the metal and the other artifacts that we get at 3T, but still have that high gradient power on the 1.5. So I'd like to demonstrate two cases for you to try to convince you how important quantitative myocardial perfusion really is. Our first case is a 78-year-old male who has a history of coronary artery disease, has had prior PCI to his LAD and RCA, and he presented with recurrent exertional chest pain. So I think all of us can appreciate that we have a large perfusion defect in the LAD territory. It's not a subtle finding. And if we look at our stress and rest perfusion, again, I think everybody can appreciate that we have this large perfusion defect in the LAD territory. And that is, again, shown on our myocardial blood flow maps here. We can see the entire LAD territory has decreased myocardial blood flow. Remember, we want it to be above 2 to be normal. And then when we look at our myocardial perfusion reserve, again, we can see abnormal myocardial perfusion reserve still in that LAD territory. So this is an easy, straightforward case that probably qualitatively would have been adequate. However, we have another gentleman, very similar case, 73-year-old patient, also has a history of coronary artery disease. He has had a prior myocardial infarction in the RCA territory and did have PCI to the left circumflex. Presents with hypertensive cardiomyopathy and hyperlipidemia. So the difference from the last patient, when we look at the SSFP images on the top left, we can appreciate here there's some regional wall motion abnormalities and mildly reduced left ventricular function. When we look at our single shot PSMDE images utilizing Air Recon DL, we can see that we have a large RCA infarct. So we've got this big area of delayed enhancement in the entire RCA territory. However, when we look at our rest on the top and our stress on the bottom, you can see that we don't see a perfusion abnormality in this case. However, when we look at the blood flow maps, rest and stress, we have decreased myocardial blood flow, and it's diffuse in all three of our cardiac territories. So it's abnormal in the RCA, it's abnormal in the LAD, and it's abnormal in the left circumflex. Now, we know that this patient has already had an RCA infarct, but we still have two territories where we've got decreased myocardial blood flow on stress, and then we also have abnormal myocardial perfusion reserve. So the question here is, what's going on? Do we have epicardial coronary artery disease, or do we have microvascular disease or microvascular dysfunction? So we have to look at our coronary arteries. And interestingly enough, in this case, remember the patients had a prior infarct in the RCA territory. We have an area of stenosis in the left circumflex territory with our epicardial left circumflex coronary artery, but our LAD is normal. So this helps you identify two problems here. You can have both obstructive coronary artery disease and microvascular dysfunction in the same patient, and this would not be able to be identified in a patient if we'd only done qualitative myocardial perfusion imaging. We're going to finish with AI-driven cardiac scanning. Cardiac MR sequence acquisition is challenging. It requires additional training for our technologists. The anatomy is highly variable, and especially in congenital heart disease. The access to highly trained cardiac technologists is especially scarce in our smaller and rural areas. And the application of AI can really help us offer cardiac imaging in more locations. But it can also increase patient throughput because you spend less time setting up the sequences. So this is the AI-powered MR acquisition. This is the description of the training of this algorithm, where they use a number of localizer images first to identify the heart and also identify the organs around and exclude those organs from being part of the setup. And you can see when we compare, they've also placed a bounding box over the heart. And then we're looking at the heat maps of the left ventricular apex and the mitral valve. And you can see in all of these acquisitions, we have excellent validation between the apex and the mitral valve. And then the same here, when we're looking at our short axis heat map, we've got really excellent visualization of all of our valves. And when we compared the AI versus the radiologist, for this is the technologist, with a number of patients, you can see that we have really excellent consensus between the three. And so this is an example of the AI-driven image acquisition. You can see that it's very rapidly setting up all of our imaging planes. And this can really not only help a patient, a site where you may not have a highly trained cardiac MRI technologist, but also in places who are doing a lot of cardiac imaging. For instance, at our site where we have 10 or 12 cardiac MRs a day, that increased efficiency, and we have a large backlog of over 30 days for a cardiac MR. If we can decrease that scan time and image more efficiently, we can see more patients and then offer cardiac MR scanning also in other more rural areas where MR technologists may be more scarce. So, efficient cardiac imaging, is it a dream or a reality? I hope in the last 40 minutes I have convinced you that it is truly a reality. Free breathing cardiac MR exams are better for the patient, they have better image quality, and certainly our increased efficiency with the addition of deep learning image reconstruction, utilizing both air recon DL and sonic DL, has really afforded us the ability to have a true free breathing cardiac MR exam. New technology with the high gradient 1.5 sprint system will give us the gradient power of a 3T, but not the challenges. And it's going to be fantastic for quantitative myocardial perfusion, pediatric imaging, our challenging patients, and patients with metallic devices. And faster imaging techniques also allow us to scan more patients and decrease our cardiac MR backlogs. And for that, AI-based image acquisition really affords the ability to offer cardiac MR scanning in more locations. So I thank you for your time. And this is a picture of my cardiac MR group at Fairfax Radiology and all of our fantastic techs, which I'm really proud of. And all of them helped me with all of this today. So I'm happy to take your questions at this time.
Thank you so much, Dr. Atkins. What a whirlwind of technologies you've just shared with us. And it really reminds me that a lot of the conventional technologies were designed assuming a perfect patient, right? For the best case scenario patient, which is obviously not what you see day to day in clinical practice. And it
Absolutely.
requires these adapted technologies to come up with a solution that is more tailored for them and is going to work in all patients. So I have a question, and then we have more questions coming in on the chat. And I invite our audience to continue to submit questions. So I want to ask you more about the free breathing protocol. So you mentioned what that protocol consists of, and I want to know, how do you select today in your practice which patients will receive the free breathing protocol? And then can you elaborate a bit more on how it could possibly be that the free breathing protocol ends up being shorter than the breath hold version? That seems very contradictory.
Yes, understood. So let me start with the first part of the question. In our practice, we will quickly move to a free breathing protocol in any patient with a severe cardiomyopathy. If they look very frail when they're walking in, if they come in a wheelchair, if we know that they have a severe arrhythmia, and or are severely claustrophobic patient population. So we do have them check off on their paperwork if they're a claustrophobic patient. And we found that having a lot of practice with free breathing MR makes all of our technologists more comfortable with it as well. So we just don't spend a lot of time, trying to do repeats and getting them to hold their breath, and just move straight to a free breathing protocol. I think it's better for the patient. It's better for the exam. And to your second question, how could free breathing be faster? I think it's taken me a lot of time to convince people that free breathing really can be faster, because you waste so much time in between each breath hold, especially when you have elderly patients who are struggling to hold their breath even 5 or 10 seconds. You then split up your segmented exam into so many little pieces that every time you wait 10 or 15 seconds for them to try to breath hold again, it just would have been a minute from the start as a respiratory triggered acquisition. And certainly it's not always perfect in our navigated sequences or patients who have really erratic breathing. It can be more challenging. But we try to coach our patients for breathing, even while we're walking them down the hallway, to get them onto the scanner, and we think that's very helpful.
It's great. We have a question about Sonic DL. One member of our audience says that they're currently trialing Sonic DL on their GE Artist system. And their radiologist noticed a decrease in resolution on the CNAs, which was worse when the R to R was decreased. So what parameters have you found that work well and that might improve resolution besides increasing the R to R?
So I think it's really important to play around with all of the parameters when you're setting these up, because it's very easy to, once you're making adjustments, if your temporal resolution starts to drift quite a bit, then certainly you're going to notice image quality differences. And I think sometimes you're not always thinking about it, and the technologists aren't either. And so one of my mentors, who I think has taught me a ton of physics, always said, when you change something on the sequence, you have changed something else. And you always have to think about what effect when you change your field of view and you make a smaller field of view, when you change your, you have to look at where your TRs are going. You need to be paying attention to the changes that are made. And what I see most commonly, I think, is people making big decreases in field of view and then not realizing what that effect is going to have. So I think paying attention to the protocol and making sure that you're keeping pretty rapid temporal resolution, keeping your voxel size at the same size. So those are parameters that always, before you make major changes into a protocol, you want to see what your temporal resolution is going to be, what your TR is going to be, um, and hone in on those factors before you start scanning the patient.
So what is your default protocol for sonic DL today on your current system?
We
What
are
are
currently
your
running 3
resolution?
R to R on patients who can hold their breath for at least 10 to 12 seconds. Our standard protocol includes everything at 3 R to R, and then we quickly have them available to change into 1 R to R and respiratory triggering if the patient struggles with the breath holds. I know there are a number of other cardiac imagers around the country using 4 R to R. My concern with that is just, the more you increase, of course, your resolution is fantastic, and your temporal resolution is going to go down, but you're going to struggle some with a segmented technique again. So when you get patients, and certainly in our practice, we scan a lot of patients with AFib, high PVC burden, non-sustained VTach patients all the time, and so I think for that reason, we have kind of leveled at the 3 R to R. I can't wait for the Cygnus Sprint, because then we're going to be able to achieve all of those, the resolution, the spatial temporal resolution at 1 R to R. But that's the reason why we haven't switched to 1 R to R for everyone today, is we just can't achieve that voxel size and temporal resolution that we would like at 1 R to R. But it's coming.
It's coming. So just to clarify, for the 3 R to R protocol you use today, how many slices are you achieving in a breath hold?
It depends on the heart rate, of course, but usually the entire is 2 to 3 breath holds,
For the whole stack?
entire stack. So if you say the average is between 10 to 12 slices, you're getting somewhere 4 or 5 slices per breath hold.
Okay. So coming back to the sprint, so you mentioned that with that system, it'll give us the ability to achieve 1 R to R imaging that does meet the SCMR guidelines. It gives you the resolution you need. I mean, would be an amazing breakthrough, because it means MR is more like echo, right? More like
Yes.
real-time imaging. So do you imagine that your clinical approach will change then to a 1 R to R paradigm for everyone, possibly?
So I think our standard cardiac MR protocol will change to 1 R to R, is my plan with the Sprint. Although we will leave some protocols for certain things, for small masses. Especially fibroblastomas or valvular masses, things like that. We will have a separate protocol for that, so we can achieve some really rapid temporal resolution and go back to some quasi-segmented technique for that. Also, we will, for some of our valvular heart disease, I think we'll have some other options. Right now, when we're evaluating an aortic valve, we frequently do 6 R to R imaging, and they look beautiful on our artists today. But even once we push that gradient power, I think we're going to have really beautiful visualization of valvular work and any small field of view imaging that we need to achieve with a rapid temporal resolution. But our standard, infiltrative viability morphology protocol will be changed to 1 R to R, and then our pediatric population certainly will change all of them to 1 R to R with respiratory triggering.
It's an exciting feature, and nice to have that flexibility, right,
Yeah,
to
and I'm
dive in.
hoping with it, especially, we try to utilize not utilize anesthesia as much as possible. There's certainly data that shows that longer exposure to anesthesia times in these children has negative effects in a multitude of ways. And so, if we can put movie goggles and have the children free breathe, we can probably right now we're at about 6 years old is where we try. I think we'll be able to push that to a much younger population with movie goggles and getting them nice and comfortable in the scanner, especially with these more rapid techniques.
Mhm. Fantastic. Couple questions about LGE. You showed us many nice cases using single shot LGE. Do you still use segmented 2D segmented MDE? And if so, in what situations do you use single shot?
We don't do segmented um, on our GE scanners where we have actually in all of our scanners at this point we're using single shot PSMDE imaging. We don't use a segmented technique anymore unless somebody needs it for some research something or other, but all of our clinical work has completely switched. In that time we have now been able to acquire usually 4 planes, 2 short axis, 1 traditional delayed enhancement, 1 gray blood, and then an HLA and a VLA stack. And all of those are very rapid. They can all be done free breathing as well. So it's about a 1 minute acquisition time, average 1 minute acquisition time for the entire ventricular coverage.
And how about the wideband LGE? Do you use that for all of your LGEs, regardless of the presence of implants?
Yes, because all of the single shot PSMDEs are wideband enabled. So you don't have to change your protocol necessarily if you're using on an ARTIS system, for instance. All of the single shot PSMDEs are wideband enabled.
Mhm. Okay. I was so impressed with the quality of the images for your really complex device patients. Um, can you tell us a bit more about what volume of patients you're seeing that come in with devices, and how do you expect that number to grow, and just the general complexity of the types of patients you're seeing? What is the
So
future?
the future, I think, is going to continue with devices. And I think they're going to continue to increase. So we set out to make a robust device program. Our previous manager, Tom Schrack, who many of you know and is no longer with us, he's gone on to bigger and better things. He and I decided, I think 10 years ago, that we needed to just embrace devices. They aren't going away. And I remember sitting in a meeting when I heard everything is going to be MR conditional within 5 years. And we're 2025 and everything's not MR conditional. So I think developing a very robust protocol where you can scan all devices is really important. And it takes time. We have worked really hard. I know when the Lynx device came out, I canceled probably 3, 4, 5 cardiac MRs because we couldn't get it. But taking the time to really work on the protocols and optimize as best as possible, and then new technology, um, new scan technology, better wideband access, having single shot with SPGR, sonic DL, all of those things have really helped us. So our device patients, we're really trying to concentrate them on our 1.5 artist. We have a number of them throughout the system, and using a dedicated device protocol. We now have them on all of our scanners. So somebody's not fumbling around like, uh-oh, we have something here. So it's easy to have a dedicated protocol. And I think that has helped. And then we don't shy away from them anymore. When there's something new and challenging and difficult, we decided we're going to tackle it we will beat you, metallic artifact. So, so I think taking that attitude and kind of embracing it has really helped.
Great. Some questions on the gray blood sequence. So can you explain again how you've implemented that, where in the protocol, and how do you adjust the TI time?
So, it is at the end, depending on the time that we have from contrast. We run a few sequences before contrast, then we administer contrast, and in that 0 to 10 minute time frame, we're trying to do a lot of our imaging. So at the 9 minute time frame, we run our cine IR and we start our routine single shot 3 planes. If we're at 15 minutes, which we usually are not, we'll run the gray blood sequence and then our post mollies for our T1 maps, or the opposite. So right around the 15-minute time frame is usually when we're running those. We for the gray blood sequence, you want to have the minimum TI your scanner can acquire, because you need that space in order to, so the phase image will correct the signal in the myocardium, so you still have nicely nulled myocardium. If you look at the mag images on these, they look very terrible, of course, because you've picked the wrong TI time. But on the phase image, you want to pick the lowest TI time that you possibly that the scanner will let you acquire. Usually it's around 175 is the lowest I've ever seen, to about 193 milliseconds. And so whatever that minimum TI time is, we'll choose that and then run the gray blood sequence. So it's very easy. It's all the parameters are otherwise identical to our short axis PSMDEs.
And you use that with ARRI-CONDL to recover signal.
Yes, yeah. So all of our delayed enhancement imaging is ARRI-CONDL enabled. We use medium for the majority of patients. If the patients exceed a certain BMI, after about a 35 BMI, we will start to go to large. So to increase the denoising associated with it.
I see. One of our audience members asked if ARRI-CONDL is available on any other model. I guess I can answer that one. Yes, it is. It's available on all of our MR systems and compatible with most of our cardiac sequences as well as all other sequences. Let's see. I think I have one more question for you, and that is about looking ahead and trying to achieve the vision of a 15 to 20 minute cardiac exam time. Do you think that with these technologies that are at our disposal or will be shortly, will that be achievable only in specialized centers like yours? Or do you think we'll be able to replicate this at other types of centers as well?
I think we can absolutely replicate this at other centers as well. I think the technology at this point is robust, and the utilization really is quite simple. The protocols are important, but I think certainly they can be distributed, and I think it can be done at any center. And something that's very important to me is access to cardiac MR. And I think if you look, I'm sure many of you have seen, or anyone who's involved in SCMR, the map of like access across just even the United States. It's really sad how there's big pockets of the United States that don't have access to cardiac MR. So I think it's important to me that we're able to distribute this technology and be able to acquire for patient populations, even that aren't in a large city like the Washington, D.C. area like we are, but even in smaller, more rural areas. I'm certainly from a rural area, a rural state myself. And so there's parts of West Virginia that don't have access close by to cardiac MR. So it's important to me, and I think it's important to the societies that everybody has access to these capabilities. Now, even if you don't have the highest level of technology, like you just mentioned, a lot of these technologies are even available on more basic systems.
Mhm. That's exciting future indeed. I think we will have to end our Q&A now. There's still a lot of questions coming in, but we'll try to get answers to those in the chat. But I want to thank everybody for joining. Thank you, Dr. Atkins, for this incredible presentation. I hope everyone was as amazed as I was just to realize how far technology has come. And you really showed us nice examples of difficult patients that you were able to obtain great image quality in. And we also look forward to the future with Sprint and better gradient performance to
Yes.
things even better. So thanks again to our audience for joining, and you will all receive a notification email from RSNA, who is hosting this webinar, when the recording is available, and that will be in the RSNA course catalog. Thank you again. Have a wonderful day.
Thank you. Bye-bye.